should all be a review for you guys. And then I hope to have that test graded by 3 o'clock today. So that's that. Okay, so the first thing we're gonna talk about with our chapter 23, we're going a little bit out of numerical order, but that's okay. There's a reason for that. So chapter 23 talks about upper and lower respiratory tract. When we're talking about upper and lower, one thing we have to talk about is atelectasis. So it's a fancy way to say a collapsed lung, or air is airless. And the reason why, 9 times out of 10, is normal chest x-ray should look like this lung side. This is your atelectasis, where there's air filling up that cavity for whatever reason. So a lot of times patients, how they can fix this is doing a sinus spirometer every hour while awake is the rule, okay? The more they use it, the better they're gonna do for impaired gas exchange purposes. So we wanna make sure that they're using it every hour while awake. We won't wake them up to have them do it, that's why it's important it's every hour while awake. So leading to this, patients who are more susceptible to atelectasis are those patients who had surgery or immobile. They're not getting up and moving themselves, and we need to help with prevention. Also, something called chest physiotherapy, also known as CPT. A couple of things. One, respiratory has, you know the commercial with the scrubbing bubbles that does the bathroom? It kind of looks like that device. They hook it up to the wall, and they can, for lack of a better word, beat on the patient with it. It causes vibration, and that vibration loosens up any secretions that you would get in that world of atelectasis. Also, as nurses, we can also give CPT. We cup our hands like a C, and we will, again, cup or beat on our patients, wanting to do the base first, working our way up. Proper technique. You don't want to do it from the top down, because the idea is impaired gas exchange happens in that alveoli at the bases, and so we want to make sure that we are loosening up those secretions to help them expectorate and get them out. So we start from bottom up at the basis, with that said. Treatment is also something called PEEP, positive and expiratory pressure. It's exactly what it says, positive and expiratory. So it gives an extra boost at that expiration. A lot of times with ventilation is they have a PEEP, and we'll talk more about ventilators as we go along. One thing they might also do if the patient's still having some difficulties is a bronchoscopy. They will remove the obstruction that's causing that shortness of breath and that distress when it comes to patients with atelectasis or obstruction. And that's also how we diagnose, especially that PCP, the pneumonia that causes those HIV patients, to make sure, or to test that fluid or mucus or stuff in the lungs to see what microorganism is causing that infection itself. So when a patient has a pleural effusion, it's a little bit different. Airless entry with that atelectasis. Pleural effusions come with fluid. A lot of your patients that have cancer, lung cancers, develop pleural effusions, and you see in that pleural space there's fluid. This is clear, a nice blue animated picture. However, when we think of pleural effusions, we think of those patients that have that lung cancer or some tumor-ish, and the white blood cells are fighting against it, and that's where that fluid comes from in pleural effusions. It's the white blood cells trying to fight that cyst or tumor that is associated in those lungs. So the idea is that they will get a thoracentesis, right? And they will pull out that fluid. It's usually 9 times out of 10 a little bit tan in color or yellow in color, and they want to remove that fluid because it's taking the place of where that lung is, and that leads to bigger problems. One of the bigger problems is what we call acute respiratory distress syndrome, also known as ARDS. ARDS became very popular with COVID, right? So one thing is, with ARDS itself, it's a rapid onset of difficulty breathing, and the other symptom is hypoxemia. So it's more than just hypoxia. Hypoxia is low oxygen levels. Hypoxemia, on the other hand, is low oxygen levels in the blood. Okay? Yes, Jessica.
You said rapid onset, oh, it's right there, sorry.
Difficulty breathing.
Okay.
And then, again, hypoxia is at low levels of oxygen. But hypoxemia is low oxygen levels in the blood. And so, what the problem with is just giving a nasal cannula for hypoxemia is not going to be enough for these patients. They're going to need to be ventilated. And one of the things with ARDS also comes, they usually say in labored breath, I just can't breathe. So it's labored. They just go, oh, I can't breathe. It's labored. They say, oh, I can't breathe. So headache also goes along with it. Fatigue, increased respiratory rate, and then elevated blood pressure or increased blood pressure. So the management of ARDS would be intubation and mechanical ventilation with PEEP, the positive end expiratory pressure. When we're thinking of nutritional support, that will come about 24 to 48 hours after. It's not priority right there to feed them and give them nutritional support. The goal is to maintain airway and breathing. That is the goal with somebody in the management of ARDS. Everything else will come later. Next disorder is PE. Patients who have a clot that could have traveled from somewhere else, and AFib, DVTs that have a traveling PE that end up in the lungs, causing a blockage. One thing is we monitor pulse oxes. O2 sats may be okay, but your patient does not reflect that low. Now we worry when it's less than 90, right? 91. So when patients are floating around 91, 92, 93, we really don't stress out about it. However, these patients will have that low in the low 90s, and they will have other symptoms like restlessness. They'll be moving all over the place. Some will be up pacing because they just can't catch their breath. But they won't be as labored as what you think with ARDS. And it's usually those patients that have been post-surgical. Those that have had some type of surgery and maybe at post-op 1 or 2 days, and they're just can't get, and they're really restless, and they're moving around. So two things that come up with PEs is how we diagnose them. So we'll talk about that in a second. With PEs themselves, just another animated picture. So you see, we already talked about infarctions when it comes to MIs, but this purple area represents the tissue that's damaged from having a PE. And so you see that purple damage is that lung tissue that's going to be infarcted or ischemic. They're never going to get that lung tissue back because they don't have that proper blood flow. And then just on the top here is just some little ones that are going at the end of the pulmonary arteries there, just little. But again, it's not so much the PE itself, it's the damage it does because it can't get the blood flow to the rest of the tissue. So a couple of things about how we diagnose them. One is a D-dimer. D-dimer is a blood test. If somebody has no blood clots, that D-dimer should be normal or 0. As the D-dimers increase, then we see that the patient has more chances of PEs or has a PE. That's what happened with ARDS, or COVID. When patients developed COVID and had COVID that led to ARDS, they ended up developing blood clots. So patients post-COVID were on Elzalto or warfarin or Eliquis, some type of anticoagulant to prevent from true PE and prevention is because D-dimers became elevated. So that's one thing that, and then of course patients who had histories would also be on there just as a precaution, even if their D-dimers were okay. The other way to diagnose would be a CT of the chest. CTs of the chest usually VQ scans. V meaning ventilation, and Q meaning our favorite word, perfusion. So patients have to tolerate with VQ scans to lay flat for an extended period of time because it's a radioactive dye that they have to inhale, and then they have to wait until it gets into the vascular area of the lungs in order to take those pictures in nuclear med. So if the patient cannot tolerate laying flat, which they may not be able to because they're too restless, then they would do a CT of the chest, which is a faster procedure, with raising their arms up above their head, and then quicker picture with a CT scan. So CT of the chest or VQ scan, and then of course that D-dimer. So the risk factors, we mentioned a couple of them already. Prevention is the goal. So if it is because of venous stasis, we want to get them ambulatory, up and moving. And then anticoagulation therapy as a whole. Now, prevention would be the SCDs, not somebody who you already suspect has a PE. Because if we put SCDs on them, when we suspect, we could actually cause that clot to travel. Okay? So preventively, before the suspicion of PE comes in, we would use the SCDs. But of course, when they have it or we're suspecting that they do, we definitely want to take those off. And then of course, do some other investigation like D-dimers, VQ scans if they can tolerate that laying down, or that CT of the chest. Other things that could happen with those patients for treatment-wise, we didn't mention, but we will. Thrombolytic therapy, there has to be a clot there, we could blast it. Keep in mind, with thrombolytic therapy, we also have to be careful of those patients who have had any bleeding disorders. So peptic ulcer disease is one in particular that we would contraindicate it with thrombolytic therapy. The other two, besides your anticoagulations, the other two meds of choice is already listed there for you, morphine and furosemide. We know morphine does a lot more. It causes that vasodilation, venous vasodilation. It also helps with pain. It also helps with pulmonary congestion. So it does so many other things. And then the morphine, or the furosemide being Lasix, helps with that excess fluid that is causing a backup because of that blockage. So we would definitely want to use both of those to help getting that diuresis started. Also, then animated picture of an umbrella filter, also known as a Greenfield filter, a vena cava filter. There's many names out there. It's all the same thing. It's a filter in the vena cava to catch any clots. Okay, but keep in mind it is a foreign object. With platelets, loves to stick on foreign objects, so they might be on some kind of long-term-ish antiplatelets, maybe not necessarily anticoagulant, and some patients, after that extended period of time of whatever the physician feels, may not need it after the fact. I'm not going to put a time frame on it. It could be years, it could be months, just depending on the patient and then other comorbidities they may have. If you think about their small vessel disease, if you think about diabetes, because platelets, of course, are more sticky when it comes to diabetes, etc. Yes, Katie?
So is this something they put in preemptively for somebody who they are worried about getting more clots, or somebody who already has a clot they put it in?
All of the above.
Oh.
Especially your gastric bypass patients years ago always used to get this pre their gastric bypass, day before. Because of it being a major abdominal surgery, they did it as a prophylactic to prevent any clotting. Depending on how bad their PE history is, or DVTs for that matter, they very well could preempt to go ahead and do it. Or it could be post, they already have them and do it. So it could be all the above. Questions about any of those? Yes.
So if someone is like allergic to like the contrast dye for the CT scan for the chest, but they can't lay flat for the VQ scan.
They don't use CT of the chest, they don't use dye. That's only for the VQ. It's inhaled radioactive.
Okay.
It is non-contrast CT.
Okay.
So that's how they get away from it. If they're allergic to shellfish, avocados, those kind of things. So patients with lung cancer, we mentioned earlier about the pleural effusions that happen with those because it's white blood cells attacking the tumors in the cyst. With that said, caring for the patient who has a lung cancer. Prevention, of course, is always the key, but causes, 90% of the time, it is caused by smoking. But again, smoking comes small vessel disease. Don't want you guys to forget that. The goal is to screen and monitor these patients. That means screen and monitor them, educating them, stop smoking, because yes, the damage is already done, but why progress it and make it worse? The carcinogens with occupational environmental, asbestos, and radon is also, asbestos has been around for a while. We know them as mesothelioma. You've seen the questions when you've had time to watch TV. More than just carpentry with asbestos is also those auto mechanics, diesel mechanics. Those that are working with brake pads, because they found that brake pads had asbestos in it, and they're moving away from that asbestos with the ceramic, etc. Couple of things about different types of our lung cancers. Small cell. Small cell grows fast and spreads early. So it grows fast and spreads early. With squamous, all these treatments that we're going to mention needs to be completed on the squamous cell. And non-small cell can be just a lung resection or surgical removal. Now, anytime we surgically remove any type of cancer, we always have to make sure that there's no tissue around that is, that is also damaged. So if there is some tissue and they don't think they got it all and those kind of questions, then they will go ahead and do the chemo and possibly radiation or possibly chemo or possibly both, depending on if they got it all and how big, going back to the TMM scenario. So if the size of the tumor matters, if there's lymph node involvement, and then of course if there's any metastasis. With that said, lung removal is the lobe removal could either be the surgical treatment. Radiation, remember, it's external burns. So we haven't talked burns yet, but it's coming down the road. So we worry about the external burns with those patients, taking away from that normal tissue. And then chemotherapy goes back to determining the dose and depending on the size of the tumor itself. When we're talking palliative care, remember it's a fancy way to say managing their symptoms. So managing the symptoms, of course, for pain, quality of life is that whole end result when it comes to palliative care. When we're talking about caring for the patient, psychosocial support, most definitely. Reducing fatigue is the goal, and then of course airway clearance. If they can't airway clearance themselves, what can we do to help them? Is it something like CPT that we need to do? Is it suctioning, etc.? So things like that, how we can help them as a whole to get airway clearance is the goal. Chest trauma. Chest trauma, fancy definition for trauma, leads to a decrease in volume, heart failure that leads to a decrease in O2 levels in the blood. So decrease in volume, heart failure, a decrease in O2 levels in the blood, or decrease in oxygen levels in the blood. So that's the definition of chest trauma or trauma as a whole. Blood trauma, usually caused by an MVC, or motor vehicle collision, or MVA. Then we think about with patients with blunt force chest trauma now, keep in mind we're talking chest trauma, vital signs, ABGs, and of course respiratory system. So when we're looking at respiratory system, right, the rate, the depth, all of that plays a role. ABGs and of course vital signs, self-explanatory. Sternal manufacturers, self-explanatory. Long time ago we used to tape, we haven't done that in years. We just have to make sure that they're stable, per se. When we're talking frail chest, it kind of goes along with the pulmonary contusion. So with frail chest is if you see the penetration on inspiration, the air is getting in. We already know that this is a negative pressure world. So we should never introduce anything positive into the negative world. So what ends up happening, as you see, is because it's a frail chest, you'll see that the air gets in and it can't escape. And so that's a problem. Because then what ends up happening in that negative pressure room, in that negative pressure area, is that our lungs will collapse because of all that excess air that doesn't belong there. then it becomes, of course, an unstable patient that needs to inflate lungs and take care of that frail chest as a whole. When we're talking about penetrating traumas, usually gunshot wounds or knives, stabbings, and then that could lead to hemothorax. We're going to talk about those in a bit. Then we have the pneumothoraxes, all based on lung. So we have spontaneous or simple. Patients who have had one are more susceptible to spontaneous. A lot of times it's the little grandmas that end up falling, and that's how they collapse the lung. And again, more susceptible to do it once, they could do it again. One of the biggest things that also happens with these simples or spontaneous is patients who have severe emphysema. We're talking severe emphysema. So when I say emphysema, you should already think impaired gas exchange. When they have enlarged ovuli, we know them as blebs, B-L-E-B. B-L-E-B, blebs. Air enters that pleural cavity or pleural space, and as you see on the frail chest, that's not a good combination. That is why they have spontaneous pneumothoraxis. Because that bleb will rupture. So it pops open, and in the world of the bleb, it can still do some gas exchange, not enough to sustain anything. Then it ruptures, and now we have bigger problems in this pneumothorax. Traumatic is air escapes and comes through a laceration. The tension pneumothorax, it usually enters, so it escapes through the traumatic, escapes through a laceration. The tension pneumothorax enters through a small laceration or a wound. So the traumatic, the air escapes through the laceration, and a tension pneumothorax means the air enters through that small wound or space. So, with that said, how are we going to fix them? Well, we're going to get, of course, orders to fix them. So here is just an open pneumothorax, and then we have the tension pneumothorax. So just some visuals where you see how the lung is inflated, or I should say, sorry, deflated. Deflated lung here, but inflated lung here, so you see the difference. So all this open area is based on air, for whatever reason. So, with that said, they will need a chest tube. So, when we get a little bit more deeper, we'll talk more about with air versus fluid in that lung cavity here in a bit. Okay, so that leads us to our next chapter,